Welcome. We're going to begin now. It's 9:08, and we have a full day ahead of us. And I just want to get everyone's attention. So if you don't look forward, I'm going to start singing, and that is not going to make anyone happy. Yes. You write them down. It'll be karaoke at lunchtime. So anyway, I want to welcome everyone to the event today, Pandemic Preparedness. I'm going to hand it over to Christy, who's really the mastermind behind all this. But it's wonderful to be here, which is a funny thing to say when you're talking about pandemics. But nevertheless, it's great to be here. There are so many people here that we've known for many years. We've been doing this work together. In the past, we were doing a lot of this work during H1N1. The work in Toronto goes back even further to the days of SARS, and before that even around TB outbreaks. So there's been a lot of concern and interest about how we do this work in the sector. Today we're going to bring together some of the results of the work we've done in Toronto. I'm going to hand it over to Christy now, who has been doing some amazing work in this area. So Christy from Trent.
Trent, yes.
There we go.
Thank you. Is everyone able to hear me? Do I need the microphone?
You need it for the filming.
Oh, for the filming. Okay. Then I need to figure out how to make it shorter. Okay. So I just wanted to say again, thank you all for coming and welcome. We have a full day today, so we're going to run until 3 o'clock. The agenda is in front of you. We're going to start off with just some icebreakers, get to know you kind of games. Steve and I are going to talk a bit about the report that's in front of you. Those are yours to keep. Please feel free to take them home with you. And then we're going to hear from a panel. We're going to have lunch. We do have box lunches coming in, a variety of sandwiches, a good selection. That got Steve's attention. And then afterwards, we're going to do a World Cafe exercise where we're going to break into small groups, talk about some topics around homelessness, pandemic planning, preparedness, and you'll get a chance just to sort of chat about the topic and then rotate through different subjects. So that's the day. If you have any questions, please feel free to stop either myself or Steve at any point. Chris is our facilitator. He is our rock star today, and I will turn it over to him.
Welcome once again, everyone. We're going to present the findings from the work we did here in Toronto. It's part of a larger project, which we'll explain as well, where there will be more information released as we go on. So we're going to go through research findings here, some background on the project, some of the findings, and then we're going to lead with some conclusions and recommendations. I think some of the conclusions and recommendations will be really good for points of discussion. All of you come with an incredible amount of knowledge yourself on this issue, and so it'll be really interesting as we go forward today. So I'm going to go through on the presentation. We're going to present for about half an hour, is that right? And then we'll have questions, and think of like really tricky ones. Okay? All right, and when those tricky ones come, I'm going out the door. Okay. So let's begin. We don't have a phaser, so I'm going to have to keep an eye here. Okay. The first thing is around H1N1. So just to remind everyone, because it's funny, it seems like so long ago, but there was a moment in Canada when there was quite a crisis and people were paying a lot of attention to this. So in 2009, H1N1 arrived. It arrived quickly, and there was a lot of concern, right? And this just the process by which it arrived, I think, is important for thinking down the road. How did information flow about it? How was it defined? What was the nature of the virus? Is it something we should be concerned about? And I recall in Toronto at that time, when they started doing mass immunization, the numbers were quite low until a young 12-year-old who was described as a hockey player died from H1N1, right? And so all of a sudden it became like the all-Canadian child. I don't mean to I'm not mocking a tragic event, but it was interesting how a pop culture kind of event kind of draws our attention to the risk. So this study we undertook right at the time. There had been a history of doing work in this area that we'd been involved in, again, around TB, Project Janet. Were you involved in that? one as well? Okay, so at York we'd been doing some work there, but certainly in Toronto around SARS and TB, there'd been a long history of looking at what are the implications for people who experience homelessness and the sector. What are the implications of some kind of pandemic? And so we had two small projects funded by Canadian Institutes of Health Research, multi-site study into, and what we're looking at is pandemic preparedness in the homelessness sectors across Canada, because we wanted to see both the contextual difference, because healthcare is organized differently across the country and in different communities. So we looked at Toronto, Victoria, Calgary, and Regina. We had a couple of other communities, but these were the ones that are our main focus. We interviewed policymakers, people involved in, practitioners involved in various levels of government. We participated in a lot of conversations with people in government at all levels of government. But we also interviewed service providers and people who experience homelessness. And this is a summary of what we did in Toronto. The larger project, I think we had about 350 interviews with people who were homeless. Okay. So the key question that's driving it is right here, right? So in what way does our current emergency response to homelessness impact on the vulnerability of homeless populations in the event of a pandemic and present challenges to effective pandemic planning? So this is like really a key question, because in Canada, I mean, you can do different things to respond to homelessness. You can focus on prevention. You're always going to need emergency services, and you can focus on moving people out of homelessness. And historically in this country, we've put most of our energy and investment in that middle part, which is emergency services, which involves a combination of emergency shelters, day programs. In Toronto, we call them drop-ins, but we don't in Calgary, right, Jeanette? And also, I would argue, the use of law enforcement, which we tend to not talk about so much, but Christy and I have spent a lot of time. So if that's how we respond to homelessness, we have to really think carefully what happens during a pandemic where people living in tight quarters becomes a problem. So in thinking about this issue, we have a number of considerations that we bring forward at the start of the project. You know, the first being that just by virtue of being homeless, you're more vulnerable to the spread of infectious disease. Your health is compromised. There's people here from Street Health, and many of you work in the sector will know this, that not only do people who experience homelessness tend to get sick more often, they often have multiple vulnerabilities at the same time. When I worked at Chow Clinic in Toronto, it would be not uncommon for a young person to come in with like 5 things they needed dealing with: a lung infection, an STI test they were requesting, they were depressed, they had scabies, and they needed some other tests. So it's complex health needs, illness more often, and the fact that the way we organize our response to homelessness contributes to that and exacerbates all of those things. And this is the next point, right? So we rely on congregate settings. You know, it's part of the politics of scarcity. We don't have enough resources, so we can't do any better. I actually think we can do better and do things differently, but we do tend to warehouse human beings who are homeless. And this isn't a condemnation of the sector or even necessarily of the funders, because it's the response as a Canadian society that we've settled on. There is great variation in Toronto. I believe there's about 60 emergency shelters, is that right? And 60-day programs. The shelters are configured in different ways, but some of them are quite large. Some of them, you know, have many people in the same room. Certainly day programs do the same thing. So where homeless people are forced to go to access services, they're often put in the situation of being in congregate environments, which can increase the risk of disease. The ability to keep clean and do those kind of practices is limited as well. And this is a key third consideration, which applies to not just how we respond to pandemics, but many things in society, how our healthcare system's organized. There's always the presumption of a home, right? So in hospitals, when we discharge people right away, get people out of the hospital because we know your chance of things getting worse increase the longer you stay in the hospital, is based on the assumption that you have a home to go to. And so if you look at even how we respond to pandemics, the information that we get that we tell Canadians to do to reduce your risk of infection aren't that easy to do if you're homeless. Like this is a common poster that Health Canada put out, but it gets reproduced all the time. Things like wash your hands often, thoroughly in warm soapy water, or use hand sanitizer. Now this is a thing that I can do, whether I'm at home or I'm up at York University. I have access to these kind of things all the time. If you're homeless, you don't necessarily have access to that. So you can't do that. Cough and sneeze in your arm, not in your hand. I think that's something people can do, but it's a practice thing. I'm still trying to learn the elbow thing. It can be dangerous, right? So, yeah, try that on a public transit. Actually, you should do it on public transit. Keep common surfaces and items clean and disinfected. Now, if you're homeless, that's pretty hard to do, and you also don't have control, even if you're in a shelter. I mean, there are shelter standards, and Toronto's updating them and has really good ones, but at the same time, you don't have control. When there are lots of people around you, it's impossible to keep your surfaces clean, and people aren't walking around with, a spray container of Lysol and a rag, that kind of thing. Stay home if you're sick, and contact a healthcare provider if your symptoms worsen. Now, there's the crunch, right? That if you don't have a home, how do you stay home if you're sick? And is staying in a packed emergency shelter the equivalent of staying at home? A fourth consideration is that we have important questions about system capacity in the homelessness sector as it currently exists, but in the event of a pandemic, what would happen? Would we, say in a pandemic, we decided to go for mandatory quarantine, right? That things got really bad and people were told by the public health officer or medical officer of health that people should stay home. What would we do around people who are homeless? Would we, is the sector equipped to deal with that? Do they have the capacity in terms of staffing? What if the staff gets sick? What if your entire staff team gets sick in your emergency shelter? What do we do? So there are important questions to consider. And the fifth consideration is this, and this is about pandemic planning and emergency planning writ large, but certainly in this area. One of the things that we found as we started working with people who do emergency response and pandemic planning is that all of these events are highly unpredictable. So no matter how well you plan, things can roll out in ways that you just won't know. What if your transportation system is no longer viable? Right? What if your police services go down? There's all kinds of things that can happen. So we need to plan, but it's, when you do planning in your agency or your service, the implementation often does not match the planning. So you can imagine in an environment where things are more chaotic. So all of these things are important when we move forward and think about pandemics. And the sixth one, this is one, Janet, I think you'll be talking about later. Right, so I won't scoop you. And I'm waiting for Janet to have some great quotes, quotable quotes. She always has these great ones. But there's the ethics, right? In disasters, human rights are often compromised. We see this all the time. We see this in Canada right now with Bill C-51, right? Like when things get scary, if I can quote Janet, I hope you're not going to use this one because but anyway, one of Janet's great lines is, that in, times of crisis, we're all too willing to exchange rights for safety as long as there's someone else's rights. And so in a pandemic, if people started to identify people as homeless as like the vector of disease, right, would we start to use law enforcement or extreme measures to control a population that is already stigmatized? Okay, about the report, I'm now going to hand this over to Christy, and she'll take it from here. And I'll stand here and drink coffee and tweet.
And check Facebook.
And check Facebook.
Okay, so as I said, the report is in front of you. It is called Facing Facts, FAQs, so it's set up as question and answer so that you can kind of skip through it, see which points are interesting to you, which ones you want to focus on. It is available as of now on the Homeless Hub website. And what we're going to follow through today in the slides follows the executive summary. So if you want to follow along as we're talking, you can just follow the first few pages. So the report is broken into different sections. And the first one looks at homelessness, health, and infrastructure in Toronto. Now, as we've said, this research was done in Toronto, and so we don't want to assume that the findings are generalizable across the country or the province, but I think a lot of the findings will be of use to people outside Toronto as well. The first one, and something that we heard over and over and over from participants, is that the homelessness sector in Toronto is underfunded and under-resourced. What we did in our research was we talked to some stakeholders to get numbers of individuals who were in shelters, in drop-in centers, and we compared that with some data collected by the City of Toronto. And what we found was that in 2011, at the time of this research, the average nightly occupancy rate of emergency shelters was almost 98%. High rates of service use among study participants means that the people we talked to were largely using shelters and drop-in centers. The most commonly accessed services at both of these, as you can see from this chart, is food. So this was the large number one reason why individuals were accessing shelters and drop-in centers. The second finding we found in this category is that social service agencies are often congregate settings. This will come as no surprise to anybody who works in the sector. A quote from one of the key stakeholders that we talked to says, "Anytime you have a congregate setting, it's easier to spread anything. This is the case with drop-ins and shelters. Ideally, you should have smaller groups, more rooms, more bathrooms. That would be better and reduce transmissions between groups." Unfortunately, this is not what we're currently seeing in the sector. So as part of the research, we asked individuals who are staying in shelters the number of other people who share their room at night on any given average night. And what we found was that 1 to 5 is by far the biggest number. So individuals do not generally have their own room. They're often sharing, and sometimes up to 50 to 99 other people in the room with them at any given time. Similarly, we asked individuals how many people on average were in the drop-in center with them. And what we found here was that 20 to 49 other people at any given time was the average. And quite often this was within arm's distance. So we asked people the number of people within 2 feet. So again, if you spread your arms, well, my arms anyways, is about 2 feet, give or take. And so we asked people, when you're in a drop-in center, how many people are standing within touching distance of you? And what we found was 5 or more individuals at any given time are within touching distance when people are in a drop-in center. So again, highly congregate settings, individuals are in very close proximity in shelters and drop-in centers. We found that homeless individuals in Toronto are nutritionally vulnerable. Despite primarily depending on drop-in centers and shelters for food, many participants also reported that they got food from a range of sources, but unfortunately many of them were unreliable or were dangerous, so out of dumpsters or from friends or from strangers. On average, only 1/4 of the participants we spoke to were able to eat breakfast, lunch, and dinner on a daily basis. And then, highly alarmingly, more than half did not have daily access to fresh drinking water. Again, this goes back to what Steve was saying about being able to wash your hands. If you don't have water to drink, you likely also don't have water to wash your hands. Homeless persons experience complex physical and mental health challenges. Overall, many participants stated that they were in good or excellent health, but then also listed a range of health conditions. Nearly half considered themselves to have a disability, which primarily involved mental health challenges and issues around depression and anxiety. Homelessness was an emotional experience, and many individuals reported that they had low motivation, and we also saw high rates of substance use. Access to healthcare is a concerning issue for homeless individuals. Only slightly more than half of the participants had a regular healthcare practitioner, and many had concerns over how they were treated by mainstream healthcare practitioners, such as when they visited emergency rooms and hospitals. Largely, participants relied on the homelessness sector to get their healthcare. So this included community health centers, drop-in centers, and shelters. Homelessness sector healthcare operates through networks and partnerships. So what we found was that the way healthcare is provided is largely an organized approach, but it's both formal and informal. So on the one hand, there were formal outreach being done primarily by community health centers, and they would come to shelters and drop-ins at scheduled time. But there was also a lot of informal arrangements going on where individuals were using their own personal contacts within the system to call someone they knew at a different agency and say, I'm sending someone over who needs health care. So it's very much a combination of formal and informal networks that operate in terms of healthcare. The second thing we looked at was preparing the homelessness sector for H1N1. So what was done before it hit to get ready for it? And in general, what was done around pandemic preparedness? Our key findings in this section. First, Toronto Public Health took the lead role in coordinating the homelessness sector response to H1N1. As an established health authority within the city, they relied on many of their pre-existing relationships and already sort of networks that they had, tables that they already sat at, connections that they had to organize and prepare for H1N1. Other key stakeholders that emerged as H1N1 leaders were Shelter, Sport and Housing and the Inner City Health Associates. And I should say that's emerged within Toronto. Pandemic planning for homeless persons primarily followed the mainstream planning approach. So when we asked stakeholders how they were thinking about pandemic planning for homeless populations, what they largely said was they were thinking about pandemic planning on the whole, and that they were just trying to extend that to homeless individuals. So despite some of the special considerations for youth, pregnant women, and Aboriginal persons, homelessness was not considered to be a direct cause of being at risk during the pandemic. As a population, they received the same public health messages, as Steve mentioned, as the general public. So cover your mouth when you cough, wash your hands, get the vaccine. Homeless persons were not consulted in sector planning initiatives. Most social service agencies had pandemic plans, but were unfamiliar with the City of Toronto's plan. So although some plans were more developed than others, the majority of agencies had already developed some sort of plan as a response to SARS. These plans were often created through consultation with officials from Toronto Public Health. Interestingly, when we asked the social service providers whether their agencies had a plan, almost everyone said they did. When we asked the stakeholders whether agencies were prepared and had plans, they didn't feel that they were as prepared as they could be. So it depends, I think, on the perception of what a plan is. So some plans were more developed and some were more of a framework that agencies had developed on their own. Pre-existing partnerships within the sector were a key source of pandemic planning support. This was a message that came out over and over again, that the networks that are established in non-pandemic times are the ones that people draw on when an emergency hits. Most agencies turn to their formal and informal partner agencies for guidance and advice on planning. Again, this goes back to the way the healthcare sector is organized in terms of homelessness around formal and informal partnerships. Unfortunately, a general lack of funding meant that even though some agencies came together and had plans, there was really not much they could do to enact these initiatives and to work together. Three main challenges emerged for the homelessness sector in relation to preparing for H1N1. And these are a lack of funding in general and for H1N1. So what we found was that budgets were generally restricted. Agencies are funded in specific ways, and they didn't have much discretionary money that they could move around to pandemic planning. There was a strained capacity for healthcare, such that individual social service workers within agencies were generally not trained healthcare practitioners. And so the expectation to take on these healthcare roles put a strain on their everyday positions, as well as they had to undertake new training to be able to do these. And then a system fragmentation, a lack of a coordinated effort. So again, largely reliant on informal networks and not necessarily formal partnerships or funding between agencies. The next section looks at the actual response. So what happened when H1N1 hit? How did the homelessness sector in Toronto manage and deal with this? The first key finding that came out of this section is that during H1N1, homeless individuals continued to use shelters at a steady rate, but were less inclined to use drop-in centers than usual. So the use of shelters remained stable during H1N1, with 62.4% reporting that they still went to shelters, which is pretty comparable to the 57.7% that we found when we asked individuals if they used a shelter in the preceding 30 days. This number is slightly lower because of the time when the interviews took place. It was in the spring, and so likely less people were using shelters. But the numbers are very similar. So shelter use did not drop during H1N1. There was, however, a decline in drop-in center usage, so 71.8% compared to 84.6%. It is uncertain what accounts for this difference, but it is likely that concerns around H1N1 did keep some individuals out, as they reported. More individuals still reported going to drop-in centers, however, than to shelters. So even though drop-in center usage declined, it was still a more commonly accessed service than shelters during H1N1. There were some operational changes that were observed within service agencies during H1N1. Notably, there were some improvements. So people noted that in relation to H1N1, there was more pandemic planning, higher levels of cleanliness within agencies, and enhanced communication between staff and clients. There were also, however, some challenges. Staff members at many agencies had to undertake additional tasks without necessarily a reduction of their existing duties. Many services and programs were changed or adapted to accommodate H1N1, and some staff members were unable to undertake their regular duties due to illness. As a whole, social service providers were well prepared to work through H1N1. There was considerable training that occurred both across the sector and within agencies in response to H1N1 and prior to H1N1. Many hosted on-site training for their employees and focused on things like infection control strategies, infection screening, the use of protective measures, quarantine protocols, and the vaccination. Staff did express some concerns, but largely it was around fear of getting sick, and they didn't want to bring home the illness to their families. The little resistance from staff that did emerge was largely related to the vaccine, and according to the social service workers we spoke to, a lot of that was addressed through open door policies and did not emerge or escalate to any kind of problem within agencies. The fourth finding is that Toronto Public Health communicated H1N1 information to agencies on an ongoing basis. So the communication strategy included multiple outputs like posting information on their website, hosting sector-wide meetings, making a health professional available for questions, and holding a weekly open phone call where people could call in. Some of the strengths of this approach was that it reached a broad audience of social service providers, established Toronto Public Health as the H1N1 authority, and allowed them to work closely with stakeholders. Some of the challenges was that there was not enough time or resources to do one-on-one visits with individual agencies. The phone calls were underutilized, and they were unable to use social media to be able to get messages out in real time. Homeless individuals did not rely on social service providers for H1N1, for H1N1 information. That said, they generally turned to healthcare practitioners or the news media for information about H1N1. It's not to say that they didn't turn to social service providers, but they were not the top source or the source they believed had the most up-to-date, credible information about H1N1. Social service agencies faced four main challenges in relation to H1N1 supplies. This was a big issue that we heard about over and over. Cost was a big issue around being able to afford supplies. Many agencies had to take that out of their existing budgets, redistribute, and that was a bit of a burden for many agencies with strict budgets. There was an issue as well around demand and storage. So some agencies did not have room for storage. Some found that as soon as they ordered supplies, they went back out again. So they weren't able to hold on to them, even if they did have room for storage. Consumption of hand sanitizer was an issue for some agencies. One agency noted that they had to actually tie the hand sanitizer to a staff desk to monitor its use. And then the fourth one is mass confusion, particularly at the beginning of the outbreak. Agencies were uncertain over whether they needed masks, how many, whether they should use them all the time or only at specific times. The seventh finding is that the strategy for vaccinating homeless persons was to hold outreach clinics in shelters and drop-in centers. This was largely coordinated with Toronto Public Health in collaboration with community health centers, shelters, and drop-in centers. The uptake by homeless clients was considered to be pretty high, according to social service providers. So they estimated that about 50 to 60% of their service users got vaccinated. But when we actually asked individuals who were experiencing homeless how many got vaccinated, we found the immunization rate was 36.9%. Now, I should say that actually is quite in line with the general population vaccination rates for H1N1. And notably, during regular influenza season, homeless individuals have considerably lower vaccination rates, generally around 25%. So this outreach effort was quite successful in getting immunization out into the community. Infection control was a priority for social service agencies. And we saw this in various ways. So nearly every agency had a plan for infection control, although some, as I said, were more detailed than others. The most common approaches included passive screening, so just checking individuals as they came in to see if they were showing any signs of illness, attempting to isolate infected clients, using protective covering, such as gloves, and providing on-site medical treatment so individuals did not have to travel to other agencies. Some challenges that emerged in implementing infection control strategies included, again, that they're often congregate settings, so keeping people apart is quite difficult. They're generally not purpose-built as social service agencies, so some agencies are repurposed from warehouses or other structures that weren't designed with public health in mind. And many are impeded by small size and or a lack of resources to be able to undertake infection control quarantine measures. And then the final section is learning from H1N1. So what did we learn from this that we can take afterwards, moving into the next pandemic and potentially a worse pandemic going forward? The first thing is that advanced flexible planning is key to being prepared for a pandemic. As with any emergency planning, of course, you want to have a plan, but you also have to keep in mind, as Steve mentioned, the parameters might change, and so you have to be adaptable to anything that might come up. Within the homelessness sector in particular, having flexible and accessible plans were considered to be the best way of meeting the complex needs of clients during the outbreak. It was also recognized that ongoing planning was needed and that this can't just be a one-time thing that you do and are done with. It needs to be an ongoing thing, and many agencies noted they would like to have yearly meetings with Toronto Public Health to review their plans, update it, and really make sure everybody is connected around coordinating the sector. And then secondly, in the event of a future, more serious outbreak, there are 5 key challenges that would need to be addressed. The first is sector preparedness and coordination. So bringing agencies together, building these networks, getting more coordination, collaboration. The second is availability of staff, making sure people are able to work to fulfill these roles. Third is the welfare of the clients. So how do we make sure service users are protected and are cared for during this time? Fourth, further strains on already limited financial and spatial resources. And then fifth, coordination with external bodies like hospitals and emergency services. So those were the key findings that are outlined in the report. And of course, there's much more information in the report if you'd like to learn more about any of those. But we just want to put out some of the recommendations that come out of this research. I'll turn it over to you so I can... Me start, or me start drinking coffee?
Oh, you're gonna, okay. Okay. The first is that more funding is needed for the emergency response, particularly at the time of a pandemic. I mean, that was an issue that came up and it's a planning issue, right? Like, how do you ensure that supplies are made available broadly and in a timely way? There are resource implications as well, just in terms of maintaining that emergency infrastructure in the case of a pandemic, because of staff considerations, for instance, that kind of thing, in a sector that is fairly impoverished already. Okay. Do you want to, or should I'll do that one and then, okay. Funding and resources are needed to meet the nutritional needs of homeless individuals, and this would have to look a little different during a pandemic as well, because a lot of people may in fact flee the shelter system I think I would, right? And so how do we ensure there's adequate food? Nutritional vulnerability is a big issue in the homelessness sector. Val Tarask's a researcher in Toronto here who's done amazing work on this. And in spite of our best efforts, the reality is that it doesn't matter if you get all your food from emergency services or you get your food through other routes. Your chances of being malnourished are quite high if you're homeless. Here, you come up. Well, it'll be like a duet.
Okay.
There we go.
All right. So funding and resources are also needed to meet the physical health, mental health, and disability-related needs of homeless individuals. Again, as we said, what we do in non-pandemic times carries over into pandemic times. So these recommendations are not just about while there's an outbreak, but it's what can we do to make our system and our sector stronger so that when an emergency hits, we already have a strong foundation. So the homelessness sector needs to systemically integrate its health services. What are some things we can do to do that? The healthcare needs of homeless individuals should be included in the curriculum of all medical and nursing education programs. And then we should also look at coordinating more opportunities for practicums and placements within shelters and drop-in centers so that while individuals are doing their education, they're learning about these issues. And under that same heading, health services within the homelessness sector should be organized as an interconnected network of formal partnerships and coordinated service delivery. So as we said, this is already going on, but we need to look at ways to make more formal partnerships because, again, these are what individuals and agencies turn to when an emergency hits.
And that also raises a planning issue in the event of a pandemic. So if the current health infrastructure gets overwhelmed, during a pandemic, what's the relationship going to be between the homelessness sector and the mainstream system? And so,
one of the things that we think might be beneficial is having a new sector-wide position to organize health services coordination across agencies. So someone who works across the sector helping to coordinate some of these networks and outreach initiatives between various organizations.
The Toronto Public Health, one of our considerations in doing this research was that Toronto Public Health did make a lot of efforts, very proactive to engage the homelessness sector and do this work. Toronto Public Health already does work with the sector in different ways, but that's a very good and strong relationship, and so we look to increase that kind of role. But it's also more broadly just the issue of public health. The Toronto shelter standards have just been released, the new ones, right, Tanya? A draft version. So anyway, I believe that some of those issues around hygiene are addressed extensively there as well. But we do understand that during a pandemic, we have to look at all those kind of issues differently. And so again, the standards will address some of these issues here. Okay. Okay. Okay.
Yeah, I know we're short on time.
Okay, over to you.
So pandemic planning must regularly occur within and between homelessness sector agencies. In the event of a pandemic, Toronto Public Health, as they did with H1N1, should be the recognized authority at the local level. Pandemic planning for homeless persons must also involve individuals with lived experience of homelessness. That was one of the gaps that we found in the planning for H1N1, was that there was no inclusion of individuals within shelters, drop-in centers. So we think that's important going forward, that happens.
That's actually a key recommendation, I think.
Yeah. Good job to us.
Yeah, well done.
Internal agency pandemic planning should be a collaborative effort, but led by a designated public health staff member. So just as agencies or companies have a health and safety worker, there should be an individual within organizations that deal with public health and pandemics.
And so this kind of planning should be ongoing. I mean, one of the typical things is the cycles. Like when a pandemic emerges, everyone scrambles. But the more that we kind of integrate planning and that idea of service integration along the way, the better we're at. Okay. I'll let you go through these.
So Steve has already touched on this around the food, simply that in the event of a pandemic, individuals might not be using services as much. So we need to look at adapting perhaps more outreach, more services outside of these organizations.
And also, we'll need a human resources plan in the event of a pandemic too, because again, it's an infrastructure that we already have rules about, like minimum staffing standards that might be compromised in the event of a pandemic. So how are we going to ensure that those resources are in place? As well as supplies, ensuring that there are adequate supplies. So we'll just go through some of these quickly. You can read all of these in detail. Okay. Finally, we're going to talk about communication. This is an interesting thing. Like, in the event of a pandemic, we know that public health agencies do communicate about pandemics, but it's a real challenge with the general public, but also with people who are homeless. What was found during the H1N1 is that public disinformation about H1N1 and immunization was quite strong. And in fact, there was an interesting study of Twitter that showed that the sources of information, the tweets that got most broadly circulated were ones that had highly inaccurate information. Public health did not use social media in an effective way, public health agencies. And so that issue of communication is a big deal, because if people have the wrong information, we can exacerbate the situation. So in terms of the homelessness sector, there's various levels of communication. How do we communicate from Toronto Public Health, who would be leading this, to the agencies and the sectors, the information they need? How does communication work between different levels of government? Because that was often confusing as well. And how do we communicate to people who experience homelessness?
Right, and that's one of the things that we found as well, is that many agencies block social media sites like Facebook and Twitter. So staff members have to check their phones and that sort of thing on their own time. So agencies should allow staff to be able to use these as part of getting information around pandemic preparedness. So in the event of an outbreak, reducing or lowering those standards and actually letting people use these tools might be a very effective way of getting communication and improving it between and within agencies.
And I mean, that's probably, I suspect that's probably not, well, I don't know this for certain, but I know that institutions, whether it's schools or healthcare or government, tend to be slower on adapting to changing modes of communication. And so even the time between when H1N1 is and now, the world has changed quite dramatically in terms of communication, the use of handhelds, social media. And so, we'll have to be ready on how to use that effectively going forward, and not wait and be reactive and just rely on printed newspapers to get the word out. That's a little shot. Okay. Okay.
All right.
That's a nice picture. Where did you get that?
You like it? All right. Should we turn it over to questions? Take 5 minutes, right?
Yeah, so
Go ahead.
it's a lot of information to take in. So it's on. Before just opening the floor, I'd like to just give you a chance to talk to the person beside you. Maybe you've seen stuff in the report, or you have questions here. You could rehearse the question. We're just going to take 5 minutes. It's not a break. We're going to take a break at 10:30. And then do the panel after that. So take 5 minutes with the person beside you, or the couple of people at your table. We'll literally come back in 5 minutes, so don't go anywhere unless you absolutely have to. And then we'll share the floor and dig into the report some more, get the information contextualized, ask questions, et cetera, et cetera. So 3, 2, 1, go. Okay, so I'll share this mic if you want to make a comment or ask a question, or draw out more of the report.
And it can be a question for the crowd.
I guess we all work at Street Health, and we definitely agree that in order to plan for a pandemic situation, you have to pre-plan before and have the adequate services available. But just from working in like the Regent Park Lower downtown East Side area, it's clear that those services aren't even there, and we're seeing more and more shelters and drop-ins close as the days go by. Like the food quality at the drop-ins that I work in, like literally worse by the week. And clearly, like, we're in a moment where the state is receding. Like, there's austerity. The social services are getting pulled back very clearly, and that's not going to stop for the next 10 years. So I'm just wondering, and I'm sure, like, life doesn't guarantee answers, as this says, but just, like, how will the funding go in terms of making sure that the services are adequate enough to deal with a pandemic? Because just thinking about it, for me, it would be a disaster at any agency in Regent Park. Like, it would take a second for, like, given the amount of austerity that's coming, the revitalization of Regent Park, where like the entirety of George Street is being revitalized. I don't know, it just makes me feel very concerned as someone that does work directly with the community about how realistically this would happen.
Okay. Well, that's that's a big picture question. I have different thoughts on that. One is you have to retain hope, right? Because otherwise you just cry. And you don't want to see me cry. But the, and for me, the hope is this, that at some point we'll start to realize that we need to invest differently and more in income supports, social services, and these kinds of things, right? And you know, if we don't, we're just going to be facing this crisis. The other piece, though, that I think is important is part of that investment in that strategy, the poverty reduction strategy, and the province is now engaging in this effort to look at this, is I think that our solution around homelessness, if we want to, like just homelessness writ large, but also with regards to pandemics, the solution will not be to just keep expanding what we're doing, because we're still responding to a crisis, right? And the point is that all those conditions that make people homeless vulnerable during a pandemic, if we had a more extensive emergency response, they would still be vulnerable, right? So our solution has to shift to like preventing and reducing and eventually ending homelessness, and so that we have a small emergency sector, right? So that's where we need to get to. That's going to require an investment. I'm waiting for a politician. I mean, we had, you know, in Alberta, the Orange Crush, yay. So a change. That I'm being nonpartisan just because I like all different kinds of soda. Diet Coke, right there. Okay, so, but anyway, you know, like I'm waiting for a politician to say, you know what, I'm going to have to raise your taxes, and here's what you're going to get for it. And we don't have any political party that's saying that at all. So anyway, that's a little politicizing there, but that's what I do.
Now that Steve's riled everyone up, I get to go. I would recommend, in terms of practicality, there's something really interesting going on in the United Kingdom right now. That's a fund, a homelessness fund put out by the federal government, I guess I will say. And what they do is they encourage partnering around public health initiatives in the homelessness sector. And so it has to be a group of agencies working together that can apply for these grants. And they're small grants, but they're for service operation. And it's a really great way of bringing agencies together for their clients. And they've found really great success around that, in particular around hospital discharge planning and finding ways to work across sectors and agencies so that individuals are rapidly housed, are not sort of going through these emergency services. And I think that's something that we could really look at doing here as well, is some kind of fund that involves or requires partnering between different sectors, different agencies, and organizations.
Congratulations on this great report. One of the strategies that's talked about quite often in influenza pandemic planning is stopping various services, either because of staff absence or because of new priorities, which is always a tremendously complex calculation to make. We know that some homeless health organizations did stop some services during H1N1, and I'm wondering if the study participants talked about that at all.
They did. Actually, one of my favorite quotes in the whole report comes out of that very topic, so thank you. One of the things that we talked to our stakeholders about was this idea of stopping services and how do you make that decision and who makes that decision. And one of the stakeholders said that they were getting calls regularly from agencies, particularly at the beginning, saying, you know, when do we stop? Can we stop? Can we close our agency? And this particular stakeholder said, you know what, you are an emergency service. You don't stop. You stop when you're the last man standing because you are the last line of defense, basically. So it was an issue that people struggled with in the outbreak, particularly at the beginning. But as it unfolded, and actually H1N1 was not as great, great's probably not the right word, but the impact was not felt as greatly, people kind of started to relax a bit. And there was a bit of a fear that agencies would start to think it was not as serious of an issue as it was. And stakeholders were concerned that it might look like they were crying wolf. And so when the next pandemic hit, would they be taken as seriously? Would their message get across? So certainly closing services was an issue, particularly at the beginning. But what generally happened was within agencies, they stayed open but closed particular programs. So they diverted individuals from more recreation programs, say basketball outreach, to health and food and cleaning and that sort of thing.
Can you hear me okay?
Ken, we need it
Well,
for the...
it's for the recording too.
Oh, I see. Okay. Thanks, Stephen and Christy. I'm sitting here at the table with people from Durham region, and I started to interrogate. I thought, okay, you've done a study on Toronto, very urban region, probably a region which has a lot of resources, and I'm thinking, okay, how are the issues different for pandemic planning in a region like Durham, or where I live, Mississauga, for that example, compared to Toronto? Like, what can we learn from your report for people in other areas?
Well, that's an excellent question, and I knew you'd have a tricky one, Harris, so thank you. No, there is a huge difference. I mean, Toronto is not just a larger city, 2.7 million. It has a much bigger emergency infrastructure for homelessness. So 2.7 million people, I think around 4,000 shelter beds. Is that accurate? Right? Durham is 900,000 people, and I'm not sure how many. I know York Region, 1.1 million people, has 130 shelter beds. So there isn't a big emergency infrastructure there, but the issues are still going to be there. It's just going to have to look different. There's still public health there. There is still service providers. It'll look different, I mean, community to community. It may be more complicated in some cases. I don't know the shelters in areas outside of Toronto as well, but they may not have existing shelter standards that are as good as Toronto. I don't know that, right? So the issues are still there, that in those communities, that has to be part of the planning. All of those communities should have community plans on homelessness of some kind, either provincial ones or HPS ones. All of them will have public health agencies. And so it's going to look very different, but there will still be things to learn. One of the advantages of the larger project we did is, including places like Victoria and Calgary, which will be reporting out on what they've done as well, is that those different contexts produce very different kinds of responses, and there are shared learnings that will come from there as well. Does that help?
One of the things, too, I'd like to add on that topic is this afternoon when we do our World Cafe, one of the topics for the tables is differences across geography. So we have people here from Toronto, but also from Peel, from York, from Peterborough, from Durham, Ottawa, Calgary, Victoria. So if you're interested in that topic of what's being done in different regions, how is it organized, then I strongly encourage you at some point to sit down at that table and chat with others around the room.
And so thank you, Harris, for advertising the World Cafe. The $20 will be on your way.
Okay, so we have a little over 5 minutes left before we want to take a break, I think. So I see like 1, 2, 3, 4 hands. And a reminder that after the break is a panel, which will bring up more issues and have more opportunity. And then, of course, this afternoon to speak with each other and get into it even more. So in terms of, consider what's best use we can make of the next 5 or so minutes, so we can take a break at 10:30, stay refreshed and focused. And I'll start here with the mic and then there.
Oops. Great. Okay, thanks, Stephen and Christy and Harris for that question. I am from Victoria, and I think there's some couple really key things, and I just want to trigger maybe things that we'll discuss in the World Cafe or even on the panel, and that is that the public health infrastructure, which you highlighted as being positive, is very, very different outside of Toronto. And I think, that's case study. So in Victoria, for example, the province of BC, both in health and housing and shelters, took a lead role, which played out quite differently on the ground. And in Calgary, there's some differences as well. Like our local public health people also took a lead because they were working within a public health provincial organization that was specifically taking a lead and said do something. But it still raises that question of what happens in rural areas, because what we were finding in our data is that even in the urban center, the focus was on urban homeless adults. So the youth organizations, for example, felt very left out. And I'm hoping you can comment on that one. And the rural outside, once you got outside of the urban core of Victoria, were also asking questions, but they were calling the homeless serving agencies, not necessarily their public health folks. So I don't know if you can comment on those two things, but I'm hoping we can cue into those, because those are huge differences between Toronto and the rest of Canada.
Yeah, well, we will discuss those things. I think those are all important planning issues. It also raises interesting questions about the characteristics of the infection, right? So like H1, like it's interesting you're saying youth weren't getting access. One of the characteristics of H1N1 was that young people, ironically, were very susceptible.
Just to clarify, it was that the youth serving agencies didn't have access to information in the same way that the adults did.
But this is the point, though, that for, the characteristics of H1N1 was that young people were vulnerable. And so why weren't they kind of like at the front line of this whole conversation?
Hey, yeah, I'm wondering if you guys examined kind of like the effects of like staffing in regards to this. Like I just think about our agency, like I would say about like a quarter of the people that work at Street Health are peer workers. And so they're dependent on OW and ODSP. They don't get sick days, things like that. So a lot of like kind of like common sense, like stay home if you're sick kind of things. Like even for myself, like I've run out of sick days, and I've been sick a lot of times, like from working in a health center, like doing this frontline work. But yeah, I think that we need to look at that a bit more, perhaps.
Well, I think the staffing issues are really key, and that's going to have to be both sector-wide, because you're going to have to think in an integrated way. But also agencies need to consider that, like what's going to happen, right? Like that's part of your agency's planning around what would happen in these cases, right? How are you going to ensure that you're still viable?
Yeah, and one of the things that we found, some of the recommendations are practical things around. One agency had their staff members fill out a chart of skills that they had so that they could file it, and in an event of an emergency, they could pull it out and move people around based on their skills. It's a small thing, but it's something that might be very useful in the event of an emergency. Other agencies noted that sometimes they had staff members work from home and call in and be able to do stuff like that. So we do strongly encourage wherever possible to think a bit more creatively about how you work with staff members during an outbreak, but certainly these issues came up a lot, and particularly around unionized environments and how to work with staffing issues.
And one thing, just one caveat, I think, given that H1N1 didn't really take off as a serious pandemic, either, and there weren't a huge number of cases of people who were homeless who had H1N1, or staff, there are limitations to what we learned from this piece of research, right? Because if it had been a more serious pandemic, if more homeless people had been infected, if more staff were infected, the outcomes would have been completely different. And the questions we'd be addressing now would be very, very different because we'd have different information.
Yeah, to that end, within our particular set of respondents, only 1.3% had confirmed diagnoses of H1N1. So it was considerably low within the population.
I'm going to suggest 2 more quick questions, one here at the front, one at the back, with maybe not a lot of time for response, and then we'll take a break. So here and there.
I'm not sure if what I really have to say is actually a question or a suggestion or whatnot. I was thinking in regards to like the hygiene piece that you guys are talking about and accessibility to like fresh water and stuff, right? It's just, why hasn't, like, I guess our city or government officials ever considered the idea of actually building like public hand washing stations in parks or at major intersections, places that people congregate, whether they are homeless or just passing by in the area? Like, I know, say there's times where I'm outside and it's a hot day and I'm sweaty, and if I could just stop for a second and wash my face, it would be convenient, and it would be a way of like increasing hygiene, not just within like the homeless population, but citywide.
Yeah, it's a good idea.
And a last comment, question, and we'll take a break.
Unlike my friend from Victoria, I'm going to be brief. Ooh, we'll fight at the break. I'm Bob from Durham. I'm an Aries. Sorry, I'll carry on now. You talked about mass confusion amongst shelter workers. How did you address that? The use of masks in relation to dealing with somebody who was infectious.
Sorry, I thought you said mass confusion.
That's what I thought.
Not everyone was confused. Mass confusion was dealt with through several meetings within the sector. So Toronto Public Health partnered with the city to have meetings where agencies were able to come and learn a bit more about the masks. And so there was a formula that was put out. I don't remember off the top of my head, but it's a percentage of this times a percentage of that plus this, depending on your situation. And so actually they were recommending, Toronto Public Health recommended not to have masks initially, unless you were in a health center, unless you were actively a practitioner. They said you don't necessarily need masks. So that helped to reduce a lot of it because there wasn't a great outbreak of illness. A lot of that fear sort of reduced. But there were meetings where everyone got to come together and learn a bit more about the masks.
Thanks. My name's Tanya. I am a research coordinator at the Homeless Hub and a PhD student in disasters and environmental studies. And I'm happy to chair the panel discussion. And I'll introduce our 3 panelists. Then they'll each have, I think we agreed on 13 minutes. It was our 10 to 15 compromise. And then we'll open it up for questions. As Chris mentioned, you have those blue sheets. If you think of questions, please do write them, and we're going to start with those when we get to the discussion part. So I'm going to introduce them in the order that they're going to speak. So to my left is Althea House. She's a manager in the Influenza and Other Respiratory Infectious Diseases Division of the Public Health Agency of Canada. She has been participating in pandemic preparedness activities nationally and internationally within the private and public sectors for over 10 years. Althea worked as a primary health care nurse practitioner in 2 community health centers during SARS and has worked closely with First Nations populations through her position as the National Coordinator for Pandemic Preparedness in 635 on-reserve First Nations communities across the country. Currently, Althea is the manager for the team responsible for the seasonal influenza statement and maintenance of the Canadian Pandemic Influenza Preparedness Plan for the health sector. I think that's the largest business card in the world. Next, we're going to hear from Thomas Appleyard, who's the manager of planning and programs with the Ministry of Health and Long-Term Care's Emergency Management Branch. Prior to joining the ministry, Thomas worked as an emergency management consultant for a number of nonprofit organizations serving people who are homeless, and undertook health equity planning related to emergency management with organizations such as the Alberta Emergency Management Agency and the Wellesley Institute. And then last but not least, we'll hear from Janet Mosher, who's a professor in the Osgoode Hall Law School. Prior to joining in 2001, she taught at the faculties of law and social work at the University of Toronto. Glad you came here. Between 2001 to 2005 and 2011 to 2014, Janet was the academic director of Osgood's intensive program in poverty law at Parkdale Community Legal Services. Janet is the editor-in-chief of Osgood's Journal of Law and Social Policy, and she recently published an article in the Osgood Hall Law Journal entitled Accessing Justice Amid Threats of Contagion, based in part on analysis of the Toronto H1N research findings. So I'm going to turn it over to Althea, and I'll keep time over here.
Good morning, everybody. First of all, I just wanted to say thank you to the organizing committee for putting this together. Thank you for inviting the Public Health Agency of Canada to participate. And for me personally, professionally, thanks for taking an interest in pandemic preparedness, because I think there's a lot of fatigue out there. And it's great to know that that folks are still thinking about it. My objectives this morning is to just give you a brief overview of how pandemic preparedness and response happens in Canada at the federal level, and then to go over our experience and lessons learned during H1N1. So given the unknowns about a pandemic, as Stephen alluded to earlier, we don't know when it's going to happen, we don't know where it's going to happen, we don't know who's going to be most affected. It may be the same that were most effective during H1N1, it may not be. But what we do know is that it will happen again. You know, over a period of about a century, we had 4 pandemics, including H1N1. There are a number of emerging pathogens occurring all the time. So we've actually developed an emerging pathogen section to our unit. You know, it's something we really have to be aware of, and one of the reasons I was so particularly pleased to see that this work is actually going on right now. So in Canada, Canada's goals for a pandemic response, in a pandemic response, I have to multitask here, is sorry about this, is first to minimize serious illness and overall deaths, and secondly to minimize societal disruption among Canadians as a result of influenza pandemic. And in Canada, we started our pandemic preparedness back in the 80s. The first public published pandemic plan was in 2004. And our plans, again, this was mentioned earlier, and I thought it was really interesting how your findings and what I'm going to speak to here today is really, really consistent. So I think there is some real validation there. Pandemic planning has started at the global level. I mean, the definition of a pandemic, right, is that it is globally, it affects us on a global level. And so originally the World Health Organization came out with some guidelines that countries should be using to develop their plans. The Canadian Pandemic Influenza Plan was built upon that. Provinces and territories are expected to develop their pandemic plans and so on down. And in your findings, in your work, Stephen and Christy, you said that you found that some organizations at the grassroots level weren't aware of what the city's pandemic plan is, and that's really critical because there is this, we used to call it the nesting effect. I haven't come across that term recently, but that's what we used to say, is that they all nest together, and they should, because they're all interdependent. So in my organization, it's a health organization, public health, and so we have responsibility for the maintenance of the Canadian Pandemic Influenza Plan for the health sector. And that's an important nuance, because what you'll find in that plan is relevant to provincial and territorial governments, other federal organizations, and other organizations, NGOs and so on, but it's mainly about health. So if you're looking for business continuity planning for your organization, that sort of thing, that's not in the Canadian Pandemic Influenza Plan. So we like to make that nuance. And the other thing as well that we realized out of H1N1, it's a lesson learned in H1N1, is we were calling the CPIP, as we lovingly call it, the Canadian Pandemic Influenza Plan. And people actually expected, they knew where the CPIP was online or on their bookshelf or whatever, and they expected to go and take this when they had a pandemic and know what to do. And that's not what it is, hence the change in the name. You see it's in pandemic preparedness, planning guidance for the health sector. So we had to be, this came out of a number of reports from lessons learned. We needed to be much more explicit about what the plan was and what it's not. So this plan, it consists of a main body that talks about large overarching principles in pandemic preparedness, which really is relevant at any level and to any organization, I would argue. It's in the 13 annexes that you get into the more technical operational types of information, where it is talking to emergency planners, health professionals, those who plan for those groups. Key elements of pandemic preparedness in the health sector: surveillance, which you may or may not have in the homelessness sector. It'd be interesting to have that conversation, how you observe and keep a finger on the pulse of what's happening across the city if you're seeing things. The communications, again, this is in health, but it's already been mentioned a number of times already that was a key issue in H1N1. Antiviral drug strategy, vaccine strategy. Again, no matter what sector you're in, those, and I'm thinking particularly of the homelessness sector, the question always comes up: you don't have a primary health care provider, you don't have a home, so where are you going to get access to these things? So it is very relevant. Stakeholder engagement, I'm going to speak to that later. And development of guidance, and then the research. So my point here is that we talk about this for the health sector, but you can see how it can relate to your organizations. And just, as said before about the report, you can extrapolate important information for your setting. Pardon me. So provinces and territories, as I think probably everybody knows, that health, the federal government does not have jurisdiction in provinces and territories when it comes to health. That is individual. And so the interesting concept that Christy talked about in the UK, they have a different system. They're not working across 13 different health, I'll say authorities, but within one province you'll have a number of health authorities, but it makes it particularly challenging in Canada. As you can see, I could talk about this for a lot longer than 13 minutes. I'm sorry. So yeah, H1N1 provided the first real test of our plan. And the collaboration among governments and stakeholders was unprecedented. And so one of the key most significant things for us that we hadn't been doing before, that we learned in H1N1, was that stakeholder consultation. So we developed very quickly a really nice outreach strategy. So the Minister of Health and our Chief Public Health Officer, who is the head of our organization, went out proactively on a regular basis to talk to Canadians about what was happening. And then also, I think it was some of your findings about what Ontario did, or the City of Toronto maybe, with the emails pushing out information and so on and so forth. That was unprecedented. And we did that in H1N1 with, I think, about 20 different sectors of NGOs. Let's see, I'm going to go through because I'm probably coming down to my 2 or 3 minute mark very soon. Another key learning that we had out of H1N1 was the value of building on seasonal influenza for a good pandemic response. And so that's why I thought it was key to say what my group does now. It's not only pandemic preparedness, but we work on seasonal flu every year. We use the strategies that were used in H1N. We practice them every year, so that when we have another pandemic or even an epidemic, we will have practiced these. And I make that point because there's significance there for you. And I jotted it in when Stephen was speaking earlier. I wanted to bring something to your attention. So we've gone through, it's all collaborative. Guidance was, yes, for remote and isolated communities. Now, somebody spoke earlier to what happens outside of the City of Toronto, but of course, as a federal organization, where we have concerns for what's happening up on Baffin Island and, you know, the outport in Newfoundland or off the coast of BC. And so what we did in the pandemic, actually I was reading my timelines last night, and WHO declared the pandemic at the end of April, and by June we had the remote and isolated task group up. And so this was a group of stakeholders from across the country who came together via teleconference to talk about what were the particular issues happening in those places and what were some of the things that were needed to address those issues. Yeah, this next one, I'm a bit chagrined to tell you about this one, but anyway, internally, we were trying to figure out, we knew we had our Aboriginal front covered. We had been working with national Aboriginal organizations since 2008 on pandemic preparedness. And then we established this remote and isolated, and then we started thinking about the others, those with physical disabilities, homeless, mental health conditions, whatever. And so how do we reach out? What's needed there? And so in the vein of using that tried and true practice, which is to use existing mechanisms, we were working through our organization, through the center that does work on an ongoing basis with such organizations, and time ran out on us, and so this meeting is reminding me that I need to revisit this when I go back to my organization. I need to revisit this. This is probably a key learning for me, and just make sure that we have this process nailed down. So when it does happen, that we won't be back where we were in 2009. My time is up. Challenges, some of the key challenges, I just wanted to make the point that you will see on here, I don't know if you'll have access, will the participants have access to the slide decks? That'd be great, because there's information in here that I think it'd be important for you to have that I don't have time to go through. But you will notice that many of the points on this slide, this consultation, this stakeholder consultation was done in 2010 and 11, so pre the work that Stephen and Christy were doing, and we're finding the same information. And so I think, you know, there's consistency there, and so I think it just helps us trust that more. I guess the couple of things that the only two that I see that weren't mentioned, mechanisms for knowledge sharing, but you're talking about the social media and that sort of thing. And then vaccine is always an issue in these circumstances. And I can respond to questions later if folks have any particular question that's burning. This is the recommendations that came out of the stakeholder consultation. And I do have a reference for this report, and it's on the website of the International Center for Infectious Diseases. That's under CIHR, where I think you got your funding for the consultations back some time ago. And so what we've done in the meantime, there's the ICID reference. We have updated our Canadian plan, and so what we did is we tried to take in all of these considerations. We learned very much that we have to have a flexible plan, because what was happening in one part of the country was not happening in another part of the country. And so jurisdictions, and even within a province as large as Ontario, you didn't have the same situation in Northern Ontario as you did in Toronto, and vice versa. So in terms of geography, demographics, cultural and socioeconomic needs. Sorry guys, I don't mean to rush through. But one of the points I do want to make is that one of the important things that we found is folks got very focused on pandemic planning, thinking about flu. And I'll just challenge you to think beyond that. Again, somebody mentioned that in the homeless sector, vaccine uptake this is regular vaccine uptake. Your tetanus, who here gets their tetanus every 10 years? You know, we have, exactly, but I bet you if you did a survey on the street, you would find that those responses would be very different. And I'm a primary healthcare nurse practitioner, and when I was in clinical practice, it was my responsibility to ask everybody who came through our system, you know, about that as a preemptive kind of sorry, I was just distracted. Preemptive strike, I guess, to make sure your immunizations are up to date. I'm saying that because we now have re-emerging vaccine-preventable diseases. You've heard it in the media: measles, big resurgences of measles. Any one of you in your organizations could have somebody come in who is not immunized, who is carrying measles or whooping cough or TB. So I would challenge you to think in an from an all hazards context, not just pandemic flu. So what that means is at all times, when you're dealing with your clients, maintain that 3-foot distance, unless there's some reason why you couldn't or shouldn't. Particularly if that person is coughing and so on, because scientifically that's about how far it would spread. Encourage public health to come in and do a routine vaccine campaign in your facility. Those sorts of ongoing everyday activities will put you in good stead when the big P comes. So there we are. And again, I'll reiterate, I think this basically says the same thing that Stephen and Christy alluded to earlier. Dwight D. Eisenhower said it. In preparing for battle, I've always found that the plans are useless, but planning indispensable. It's how we work together, and the relationships that we build is what will stand us in really good stead. And thank you for your attention. And sorry I had to rush.
Okay, great. Thank you so much, everyone. Thank you so much, Christy, for inviting the ministry to be part of today. This has already been tremendously useful for us at the ministry, and I know we've learned a lot already, so really appreciate being part of this. I was asked to speak for about 10 minutes. I didn't get the 13. I was offered 10. So I'll try to keep it to 10, to speak to a couple things. The province's response to the H1N1 influenza pandemic, and then secondly, provincial influenza pandemic planning. So the good news is that the two people who wrote the books on these two issues are here in the room. The bad news is that I'm not one of them. But so I really want to give full credit to my colleagues, Katrina and Sarah, who literally wrote the two books on these two issues. So really what I'm going to be referring to a lot is their work. But we were talking about answers earlier, and answers that you can't give or questions that you can't answer. Just because I can't answer them doesn't mean that Sarah or Katrina won't be able to. Here's the book that Sarah wrote, and it's a document that outlines really what the ministry's response to the H1N1 influenza pandemic was. It's sort of a summary of both our documentation, the results of quite an extensive debrief and review process that happened afterwards, as well as an integration of a couple of reports that the Chief Medical Officer of Health wrote about the H1N1. I'm not going to go through that report, but I will highlight sort of what the major areas of activities for the province were during H1N1. Not an exhaustive list, but the major areas. So first of all, the province was very involved in surveillance, sort of trying to answer, who's getting sick and how sick are they getting and why are they getting sick? What's this disease like? The ministry worked really closely with Public Health Ontario on trying to answer those questions, and obviously that was an ongoing activity during the pandemic as well as after. Another area of activity was guidance. Guidance, occupational health and safety guidance for people providing health care. How can you do this and stay safe? Infection prevention and control guidance. How can you do this and make sure that other patients, clients, residents are safe, that your organizations are generally safe, as well as information and guidance on how various other provincial programs were going to roll out. And we'll sort of talk more about what some of those were. Third area of work for the ministry during H1N1 was public health measures, providing support and coordination for public health units that were doing their own public health measures. And by public health measures, I really mean those sort of non-pharmaceutical, so not talking about drugs or not talking about vaccines, but other things that you can do to sort of slow down the spread of the virus, slow down the spread of the disease. So we worked with public health units on their rolling out various public health measures, as well as we did quite a lot of public communications of our own, much of which was very fairly critiqued by Stephen earlier today, the wash your hands, try to isolate yourself when you're feeling sick, those kinds of public health messages. Fourth, the province had a big role. We had stockpiles of personal protective equipment, those gloves and gowns and masks that we had for the health sector, as well as immunization supplies, and we provided those for the health system during H1N1. We established and funded influenza assessment centers. So these were temporary resources that either single organizations or groups of organizations would come together to provide a very temporary arrangement, sort of access to a primary care-like model where people could go if they think they had influenza, a sort of a supplement knowing that there are strains on primary health care, strains on emergency departments. This was a way to sort of boost up that capacity. Another area of activity for us was we had antiviral medications, the drugs that you can take if you think you have influenza, and we distributed those primarily through pharmacies for free, but also a small number of homeless shelters, quite a few community health centers and Aboriginal health access centers, and then those influenza assessment centers I mentioned earlier. And then finally, the final big area of work for us was the immunization, the rollout of the provincial strategy, and I'll talk more about that momentarily. So digging just a little bit deeper into a couple of those areas of activity for us. First, on the antiviral front, mentioned that we had a supply and we rolled out that supply. We gave out that supply for free during the influenza pandemic. Bit of a timeline here. So quite early in the pandemic, provided that supply to isolated First Nations communities. And then in the fall, so the fall of 2009, rolled that out through a number of community health centers and Aboriginal health access centers, and then finally through pharmacies for the general population. In terms of supplies and equipment, again, this is primarily personal protective equipment, those gloves and gowns and masks. Again, we had a supply, making those things available for the health sector, for, again, community health centers, Aboriginal health access centers, long-term care, paramedic services, a number of sectors in the fall that we made those things available to them. You can see that these strategies are fairly simple and straightforward. Not so true for immunization, for vaccine, and I'm sure some of you remember just how complicated this became. I'm not going to try to explain this image here, but it certainly is at a minimum a demonstration of just how complex immunization rollout can be and the number of players involved. But at a high level, the provincial role is certainly ordering supply for the province, working to establish sequence groups, and then providing guidance and support to the field, the primary care providers and the public health units and others who are involved in actually delivering the program. So that's a little bit, a very, very brief summary of what the province's activities were during H1N1. So I'll shift now to what's happened since H1N1. What's the province been up to, the Ministry of Health in particular, in terms of influenza pandemic planning. So a few landmarks here. First was a major review, an update of the ministry's emergency response plan. That sort of all hazards plan that Althea was challenging us to have, as well as a major overhaul of our hazard-specific plan, the Ontario Health Plan for an Influenza Pandemic that we affectionately call the OPIP. So it rhymes with CPIP, which is the plan that Althea was referring to. And that's literally the book that Katrina wrote. We've also become quite a bit more involved since H1N1 as a ministry in coordination around seasonal influenza planning and response, and have really tried to make those links between what happens in healthcare during seasonal influenza and during an influenza pandemic. We've really been focused on role clarity enhancements. What's the role of new organizations like Public Health Ontario and the local health integration networks in their roles in influenza pandemic planning? in the past year, we've been at times singularly focused, but certainly focused on Ebola virus disease readiness. And now we're really turning our minds to the question, what is the health sector together? What have we accomplished in our readiness around Ebola that we can apply to other infectious disease emergencies? So mentioned that in 2013, the major overhaul of the Ontario Health Plan for an influenza pandemic was published. So what stays the same? The scope of that plan is really similar to what Althea said. This is a plan for the health sector. And basically the categories of activities that I mentioned during H1N1 that the province undertook, those are the kinds of activities that are referred to in this plan. So what's new? What's different about the new version? First of all, this is a bit different from how Althea framed it. We have switched the Ontario Health Plan for an influenza pandemic into a response plan. It used to be a preparedness guide, and we've tried to really frame it as something that is a bit more pull off the shelf and provide that guidance during. A major emphasis on roles and responsibilities, a place where those links to seasonal influenza, the things that we've been learning as we've been more involved in that coordination, are documented. I'm going to talk more about the last 2 points momentarily, but just to hit on them, a range of transmissibility and severity scenarios are explored in the OPIP, and an increased emphasis on what the OPIP calls vulnerable populations. I'm going to touch, last 2 things I'm going to talk about are those 2 points. So the OPIP explores in this, one of my favorite things in the world, a 2x2 matrix, various scenarios that could happen during an influenza pandemic. So in terms of transmissibility, we ask ourselves questions, how easily transmitted is this virus? How many people are likely to get sick and how quickly as this rolls out? And then a clinical severity kind of an axis. How sick do they get? How many people is this killing? How many people require inpatient care? And obviously there's a huge range in these things. What we experienced during H1N1 for most populations, most but not all, was that sort of low transmissibility, low clinical severity quadrant in that matrix. The stories that we've heard about during 1918, the pandemic almost a century ago now, much further out there in terms of transmissibility and severity. So we've tried in the OPIP to really recognize that a whole lot of different things can happen, and that this is a model that we can use to understand what kinds of responses may be necessary. In terms of vulnerable populations, we've used a model that the emergency management branch has used for quite a bit of its planning. And in the OPIP, the ministry's flu pandemic plan for the health sector, requires responders to take various needs into account. And this is the model that we've used to encourage that to occur during a response. To really take into account those most likely to be exposed to influenza, those most likely to have a serious impact because of influenza. So if you get it, what could the impact be? Those least likely to benefit from interventions. So we have the rollout of our programs. This is where we sort of get into the things that Stephen was very fairly critiquing earlier. We have our rollout for the general population around stay home if you're not well. Who doesn't that work for? And the OPIP really encourages people to take those needs into account. And then finally, and this is one of the more interesting areas, I would say, one of the things that I hope we can explore, those who may actually be harmed by the response and recovery measures that we put into effect during a response. Not only does it not work for them, but they may actually be harmed because of the things that we're doing. I understand we'll wait for questions, so thank you very much for your attention.
Thanks very much for the invitation to join the panel. I think my talk's going to be a little bit different. First, I do not have a PowerPoint. I've got notes. The second is I'm going to focus a little bit more on a legal perspective. And I'm going to start perhaps as all good lawyers do, with a caveat. That is to say, I don't regard myself at all as an expert in pandemic preparedness. But what I hope to be able to do is to draw upon a work that I've done on social justice, legal rights, and access to justice for marginalized populations to offer a few insights about our approaches to pandemic preparedness and pandemic planning. And where I want to start is actually by zooming way out, high level overview, thinking about conceptual frameworks. And those conceptual frameworks, I want to suggest, are really critical for how we understand and thus how we respond to pandemics. Are there fans of Thomas King here? The Truth About Stories, yes. You might think about this as a lesson in the truth about stories, that there are two very different stories that are being told about pandemics and about pandemic planning, and which story we choose to tell, that is, which frame we use, has really important consequences, and in particular, I want to suggest for marginalized or vulnerable communities. The two broad frameworks, and this categorization isn't original to me, you'll find it in some of the literature. One framework is national security. Pandemics as national security threats. And the other broad framework is one that some call health equity and some call social justice. So two broad frameworks, and they compete for attention. Some would say the national security framework is winning at present, and maybe a question for us is, what can we do to defeat it? So if we extend the battle metaphor, the battle might be between these two different, very different conceptual frameworks. So let me say a little bit about each of these frameworks and the difference that they make. So this will be a quick overview. So pervasive in a lot of the pandemic planning literature is an analogy, a very explicit analogy that's drawn between contagious disease and terrorism. Both are depicted as threats to national security and best managed through various kinds of surveillance and containment using borders. You might think in the national security context and terrorism as securing the borders of the nation state. Think of the analogy internal to the state, the containment by constructing borders through quarantine, isolation, and social distancing. Another mechanism of containment, and also through control. To give you an example of this, I'm going to quote briefly from Canada's 2004 National Security Policy. So, quote, "Terrorism is a global challenge that has been recognized by the United Nations as a crime against humanity. Canada is not immune to this threat, but the threats we face are not limited to terrorism. The SARS outbreak demonstrated the power of individuals to unintentionally transmit threats around the globe at the speed of air travel. The government is determined to pursue our national security interests and to be relentless in the protection of our sovereignty and our society in the face of these new threats." So our sovereignty and our safety, our society is threatened both by the terrorist and by the person who carries contagion. In this particular framing of pandemics as a threat to national security, law plays a particular kind of role. So I'll say a little bit about law. There's increasing attention paid in pandemic planning and pandemic preparedness to a notion of legal preparedness. And primarily what this means is that public health officials, police, and others have the kinds of legal powers that they would need, and that they understand those powers and they know how to exercise those powers. And largely what's imagined here is an extension of the coercive arm of the state. Greater ability to be able to apprehend, detain, and to treat people against their will. We in Ontario currently have legislation that enables all of that to happen. Some of those powers were expanded during the outbreak of SARS. And I'll come in a moment, I hope, to some specific recommendations of the SARS Commission to change some of that framework, which have never been picked up and adopted in Ontario. So this particular approach that would expand the coercive powers of the state positions individual rights to liberty, for example, to privacy, to security of the person, all fundamental rights protected by the Charter, positions this in opposition to public health. So these are, again, if we go back to the battle metaphor, these compete with each other. One threatens the other, that is, the individual threatens public health. Justice Campbell, in the work of the SARS Commission, referred to the need to ensure the delicate task of balancing individual rights against the right to the public to be protected against infectious disease. Now, some limitation on our rights to liberty, privacy, security are widely recognized. So Section 1 of the Charter recognizes that limits on those rights are permissible if they're reasonable and demonstrably justifiable in a free and democratic society. In the international context, the International Covenant on Civil and Political Rights permits derogation of rights in some circumstances, including in relation to public health. And there's a set of interpretive guidelines that have been developed called the Syracuse Principles, and they provide some guidance about when derogations of those rights might be permissible to protect public health. And I'll list these quickly and then focus on a couple of them. One is the derogations must be in accordance with law. So you have to have a statute where you spell out those limitations, and we have that. There must be a legitimate objective. So protecting public health is a legitimate objective. They must be strictly necessary to achieve the objective. They must be based on scientific evidence. They must be the least intrusive means available. They must be neither arbitrary nor discriminatory. They must be respectful of human dignity, and they must be subject to some kind of judicial review. There's more specific literature in the pandemic planning context that spells out what those principles might look like for pandemics, and I'll just leave that for now because I know I don't have much time. The nub of the concern, expressed in particular by those concerned about civil liberties, is that there's great skepticism that in the context of an actual pandemic, where people are feeling unsafe and threatened, that we would have the kind of careful assessments imagined by the Syracuse Principles or the very delicate kind of balancing that Justice Campbell suggested was absolutely essential. So let me say just a little bit about the assessment of necessity, and I'll go back to something Stephen gave an example earlier today about H1N1 and how the whole dynamic shifted when there was a lot of media reporting about the death of one young man, a tragic event. But the way in which that was reported created enormous level of fear. The media play a very significant role in how we come to understand the nature of the threat, the potential lethality, and the potential sweep of any kind of threat. Very often what we respond to politically is not a scientific demonstration about the nature of the threat, but rather a public perception about the risk to fear and safety. Some would say that governments sometimes very intentionally use strategies of inculcating fear as a tool of governance. And we might think about other examples, national security and terrorism. We might think about the proliferation of changes to the criminal code, mandatory minimum sentences, all based on ideas about risks to us, notwithstanding empirical evidence that shows declining rates of crime. So a real worry that, in fact, measures taken that might be infringements of one's right to liberty, security of the person, or privacy would actually be demonstrably necessary. Non-discriminatory and grounded in respect of human dignity. We know from lots and lots of evidence about past pandemics that those who are most likely to be blamed as vectors of disease, most likely to be cordoned off, contained through quarantine and isolation, are socially marginalized populations, sometimes based on race, sometimes based on being visibly homeless as examples. We also know that those who are socially vulnerable bear the largest burden of any kind of disaster or any kind of pandemic. We also know, and this comes is clearly evidenced in the work that Stephen and Christy reported on, that we're those of us who live in Canada, we're often very, very differently placed in our ability to be able to voluntarily comply with public health directives. If you have access to lots of resources, so you can follow all of the directions, you can stockpile supplies, you can wash your hands regularly, you could self-quarantine, you're in a position where you're able to comply. That's not true for lots of people. Lots of people can't comply because they don't have a home. Lots of people don't comply with public health orders, for example, not to go to work, because they have to go to work because they don't have any other way to feed and sustain their families. I have to put my glasses on to read that. 2 minutes, okay. All right, I'm gonna have to go even more quickly. You might recall Syracuse principles also refer to the importance of being able to legally review any kind of public health order that might be made against you that would limit your privacy, your security, your liberty. Here, the SARS Commission said this of Ontario's statutory regime, that there is some kind of review possible, but here's how it's described, and it hasn't changed. Confusion and uncertainty are the only common threads throughout the legal procedures now provided by the Health Protection and Promotion Act for public health enforcement and remedies. So confusion and uncertainty, the only common threads. The way this regime is presently structured, and given, if we're thinking in particular about socially marginalized populations, there's actually no way in which one would be able, in a timely way, with access to effective counsel, to indeed get oneself before a court, assuming courts were even operating during a pandemic, in order to have that order challenged. So just in sum of this national security frame, where persons who have or potentially have a communicable disease are cast as a threat to national security, and where fear is cultivated, the necessary transgression of individual rights becomes all too readily accepted. It is almost a foregone conclusion. And that, I think, signals some, or ought to signal for us, really, really important concerns about the socially vulnerable populations that we work with. So now, in a minute, I can say the competing frame or narrative, which I think will be familiar to you, is the health, equity, or social justice frame. And it doesn't draw from national security, but it says, what are the lessons we could learn from past pandemics, and what could we learn by paying really close attention, finely grained attention to social context, where we're not dealing with an abstracted public or nation, but we're looking at the particularities of individuals who inhabit that space. And I'm just going to touch on, because I don't have much time, what I think are some of the key features of this approach. One is voice and participation of marginalized groups in pandemic plans. And that means direct participation of marginalized groups in pandemic plans. Some of you may know or be familiar with the Bellagio principles. It's a statement of principles about the social justice and pandemic planning that says those who are socially vulnerable or marginalized must be included in the pandemic planning process so that their needs are specifically identified and concrete plans are made to address those. Another feature, access to timely and trusted information. Again, a key thing to pay attention to from the study that Stephen and Christy did and others have done is knowing and understanding who are trusted sources of information. And when we think about the conveyal of information, this will be true in your sector, it's certainly true in thinking about community legal education, is we can't operate from an assumption that there's something that's information that we can just transmit readily to everybody in a way that that little package is received and understood similarly. But rather, we have to work very closely with the recipients of that information who are differentially placed to understand what it is what are their informational needs and how do we actually reach them effectively. Okay, so a couple of other key points. And I might have left the rest of my notes behind, would just say, okay, well then she just doesn't get to the last part of her study. Okay, I did leave a page behind, but I think I can remember the last part. Again, a fundamental principle is paying attention to discrimination. And so as we do pandemic planning, how is it that we develop plans that ensure that there isn't discrimination against vulnerable populations? So just to conclude, we have, I think, these two competing narratives, national security, health equity, or social justice. I think my assessment from my reading is the national security paradigm has a huge amount of power, as I said before. How do we contest it and challenge it? There are some positive developments. I think the 2013 revisions to the provincial plan, which specifically identifies health equity and articulates a view of health equity, is a significant development. Yet at the same time, if you read the social policy literature more broadly, I think back to a comment made earlier, but sorry, I don't know your name at the front table here. If we look at social policy more broadly, I think we have cause for great despair because we know that there's massively growing income inequality. We know that the language of equality has been replaced by the language of efficiency. We know about austerity measures. And so there's a lot that's happening around us which causes me, unlike Stephen, causes me despair, not hope. But I do think this is the group of people, along with other allies, who are positioned to be able to counter the national security narrative. And we need to think also creatively about who are our allies in that work. And so those who are doing the anti-terrorism work are actually, I think, among the allies that we can find in this project. Thank you.
Thank you to all our speakers. And before we go into questions, I just want to take a couple minutes and just have you talk in your groups. What were the highlights for you? What was missing? What are the questions you have? And then use those blue sheets and let me know if you've written on any already, and we'll go into questions.
In the legal literature.
Okay, we have 3 questions so far. So we're going to start with that, and then we can continue these conversations during our lunch. So the first question is, can you comment on the role of public health measures to focus on upstream actions that could reduce vulnerability to threat of infectious disease for people who are homeless? For example, is it imperative to focus on health equity and social context? Althea, you want to start?
No.
Thomas?
Great, thank you. Yes, I guess is the answer to the question. I mean, there is a big role. Addressing the social determinants of health as a public health measure makes a whole lot of sense. I mean, that's abundantly clear. One of the ones, the angles that's really interesting in terms of influenza pandemic planning that has come up is the role of sick days, and certainly there's been some terrific research coming out of Boston in particular that's looked at sort of neighborhood by neighborhood analysis of who gets particularly hard hit during an influenza outbreak, even seasonal. And they've certainly found that in neighborhoods where people tend to not have access to sick time as part of their benefits package are the neighborhoods that tend to get particularly hard hit. And that there's been some modeling done around sick time, which has suggested that a fantastic sick time policy would be far more effective as an intervention than immunization would. So yes, there's a huge role for these kinds of things. The other thing that I'd love to think about, which is certainly an interest of mine, is the role of sort of in the immediate days after an emergency, during a recovery period. And certainly this is something that Rebecca Solnit has researched a lot, is what's the role during that period for advancing those agendas, for addressing the social determinants of health? Those tend to be times of great social change. Those tend to be times when bottom-up planning can be really celebrated, because it's the thing that's actually worked during the emergency, that the national security agendas have typically failed. So in those moments, those are times when there often is great positive social change. So I'd love to think about that in terms of influenza pandemic planning as well.
Our next question is, we're in a stage where the Canadian state is cracking down. Look at Bill C-51. Social democracy is only relevant as long as there's stability, but there's currently not stability economically, both globally and in Canada. What does this realistically mean for vulnerable populations? Janet, do you want to start on that one?
Okay, it means realistically, and I agree that there's lots of instability, and the direction things right now is, as I said before, very concerning, and that has really alarming implications for socially vulnerable or marginalized people, and that's why, I think so much of our efforts really need to be focused on getting at, in a really much more fundamental way, those social determinants of health. So a right to housing would be, near the top of my list. And just in that context, though, some of you will know there is a constitutional challenge that was brought by 4 individuals and the Centre for Equality, Rights and Accommodation. And it was launched a while ago. It was arguing that there was a constitutional right to housing, and it has been strenuously fought by the governments of Canada and Ontario. And in fact, the judge, what the lawyers for the 2 governments did is they brought what's called a motion to strike for no reasonable cause of action, basically to say you shouldn't be able to proceed and adduce your evidence because there's no reasonable chance that you could ever win this case. And the government won on that point, including at the Ontario Court of Appeal. At the Ontario Court of Appeal, heard by a 3-judge panel, they divided it 2-1, 2 for the government, 1 in favor of the 4 homeless applicants and CIRA, and they have just now sought leave to appeal to the Supreme Court of Canada, and this is all being fought out, another battle, just on the question of whether or not the applicants, the homeless individuals, can even present their evidence to the court to make the argument that they have a right to housing. So that also tells us that there's just a huge amount of work to be done in order to try to secure those social determinants of health.
So then what'll probably be our last question based on time. Who is actually considered the people or the public in a pandemic? The vast majority who are most vulnerable, or the few on top who have the easiest access to healthcare services and facilities? Althea, do you want to?
Who is considered the public?
Mm-hmm. When we talk about public health and public health agencies of Canada.
Am I talking as Althea House or as a federal servant? Well, the public obviously is everybody, all Canadians. The thing about a pandemic, though, is based on epidemiology of whatever microorganism that comes out, that's going to identify who is most affected from a medical or scientific kind of perspective. But as we saw in H1N1, there was, for some populations, there was no, you could not, from a biological level, explain why First Nations people were more affected. And it wasn't, when the analyses were done, it wasn't because of lack of access or more people in one home, that sort of thing. So there is some scientific basis that we have yet to determine. That said, though, we also know that that those who are more vulnerable from the social determinants perspective were more affected. But going back to something that was said way earlier on in terms of vaccine uptake and so on, in our consultation meeting that we had a few years back, Stephen, you attended that, and there were some really great success stories when, at the grassroots level, using existing systems, folks did what they do every day, but then, adapted to what was happening, had the public health nurses come into those environments, had vaccine clinics in those environments. And so who is the public in a pandemic? I can't say that. I can, give you my explanation of who's most vulnerable. But the public is all Canadians. We do have to think about those who have money in their pocket and a roof over their head, as well as those who have none of those things. So it's all Canadians.
Okay, thank you.
Maybe just one thing to add to that is in using the language of all Canadians, you probably refer to all of those who are within the territory of Canada, but it also calls to my mind as well a population that's often socially very vulnerable are those who are in Canada who don't have, who are not citizens or do not have permanent resident status, and the risks that they often take if they reach out to try to access services, and those risks are primarily related to potential deportation. And so when we think about all Canadians, we need to be thinking about all of those who are we have to think about all of those inside of the borders of Canada, but we also obviously need to be thinking in a kind of broader international frame as well. But I think over and over, those without citizenship status or without permanent resident status are identified in the literature as a particularly vulnerable population, not only because of their status, but their status means they're often very low income, precariously housed, et cetera.
And if I can just respond to that, that was indeed a consideration when it came to our vaccine strategy in H1N1. It was all people within Canada. Anybody in Canada who wants vaccine, were able to get a vaccine, did not need a health card, anything like that. And that was the very discussion, is because we didn't want to end up in that position. So those discussions did take place in the and were acted upon in the H1N1 vaccine strategy. Mm-hmm.
Okay, so we are out of time. We're out of... I'm looking at Chris because he's in charge.
The homeless vaccination rate in Calgary was much higher than reported in Toronto. Mm-hmm. And so we can't just do a global sweep and say it's all of Canada. We need to look regionally and say, how are there regional approaches that are more effective?
Yeah.
Okay. So if you have other questions, write them on the blue sheets. There's painter's tape at the front, and you can stick them on the walls. I'm going to turn it over to Chris in a second for details around lunch and what's next. But first, I want to thank our panel for their contributions and the expertise they brought today.